Hi everyone, thanks very much for coming along to my webinar on how to look after your own low back pain. I know that there's a lot of information that circulates through the community in terms of you should do this or you should not do that. There's a lot of conflicting messages, and I wanted to take this opportunity to try to sort of separate some of the noise from the signal and go through a little bit on what people can actually do from a practical standpoint that's been shown to work, that we do every day in clinic to help people to self-manage their own low back pain. So, a little bit about me. I'm not going to spend very long on this slide because no one really wants to hear me talk about me. I'm a chiropractor. I'm a Moonee Valley local. I went to St. Bernard's College in Essendon, graduated in 2005, studied chiropractic at RMIT, and then went on to do some courses in neurological rehabilitation and orthopedic rehabilitation, floated through some different private practices over the year, found myself in workplace injury management, where I then found myself looking after a lot of occupational injury data, doing some research and development work for them. Founded a company called Tisserie Education, where we actually provide professional development for allied health professionals, and was also an epidemiologist in the COVID response for the Victorian government. So I've had a bit of a diverse career. I'm currently now working in Travancore and seeing patients, which is what I love to do. It's why I've come back to it. I love sharing this kind of information. It's what I'm absolutely passionate about, and very grateful for the opportunity to share with whoever might end up watching this webinar. Without further ado, so when we're looking at someone with back pain, really there's two important questions that we want to answer. The first one of them is, what is actually causing the problem? Okay, so not just what is causing their symptoms, but what might be driving the actual problem. The symptoms are normally things like pain, problems with movement, maybe it's interrupting certain activities. Please forgive my writing on the iPad here. But these things, they are just that, they are symptoms. They're not actually what's driving the pain. So we want to know what is actually causing the problem. And then after we've figured out what's actually driving the problem, how do we get to it? How do we actually get to that underlying mechanism? So even though someone might have pain through a particular joint in their lower back, that pain might be through any number of reasons. It might be from some irritation of one of those joints, which might have occurred as a result of a fall or a motor vehicle accident, or it might be a lot of postural strain over a long period of time, or it might be a particular sport or work-related injury. And these problems have different mechanisms behind them, and we want to make sure that we're not just trying to get to that symptom, we're trying to get to the underlying mechanism, so that we're not just sort of putting a band-aid over the problem and hoping that it goes away. We want to actually get to as close as we can, and it's a very, very difficult, complex thing to do, but as close as we can, we want to get to what is actually the underlying cause of the problems that someone is having, whether that's pain or problem moving or some weakness, inability to perform certain activities. We want to get to that underlying cause. So there are certain principles that we use when we're looking at how to help someone to manage their back pain. So we want to make sure that we're identifying the objectives and goals of the person we're treating. So for some people, this is the complete elimination of pain, where they say, I want to be pain-free and never have to worry about this problem again insofar as possible. And for other people, it's just, I want to be able to self-manage flare-ups. So low back pain, as we'll discuss shortly, is often a relapsing condition. So one of the best predictors of whether someone will have any further low back pain is whether they've ever had previous low back pain, because it does tend to come back. And we've got some facts and figures that we'll go through shortly. So we want to make sure that we're working towards patient goals, whether that's get rid of the pain, try to make my back bulletproof thereafter, or just give me the ability to manage flare-ups. I can deal with a little bit of pain and discomfort here and there, but I want to be able to play footy, play with my kids, sleep comfortably, do all these sort of activities of daily living, and know that if the pain creeps up, then I've got a way of actually managing it. We want to consider the patient age and general health condition. So we would not treat someone who was overweight and diabetic with the same methodology normally that we treat someone who was 21-year-old athlete and a track and field superstar. So considering patient age, where they're at on their general health journey. as well as identifying occupational and lifestyle factors. So in addition to someone's sort of lifestyle and health, what kind of job are they doing? Are they sitting all day? Are they on the tools, at a factory all day? Are they doing something which is, involving a lot of lifting? Are they working at a grocery store and they're constantly unloading boxes, loading shelves, doing all the work that comes with, these fairly highly repetitive manual types of tasks? And then, as spoken about before, we want to consider the actual mechanism of the injury that the person is presenting with. And then there's some clinical management things that form some of these basic principles. And these are, we're trying to encourage people to have, helpful interpretations of their pain and injury. So when someone's injured, there's kind of two ways of handling that. And they're fairly, to me, black and white, good ways and bad ways. The bad way is to be fire and brimstone, really draconian. Hey, look, Mike, you've got this pain, it's really not good, you're going to have to pay a lot of attention to it. Giving the kind of messaging that's going to sound really kind of doom and gloom. And we've all heard of a friend who's been through this before, where they've gone to their doctor, their chiro, their physio, their whoever, and they've got that really kind of that unhelpful sort of doom and gloom version of things, rather than the more helpful, the more kind of positive influencing of a patient's set of beliefs about how to interpret that pain and injury. So not all pain is bad. In fact, usually pain is not bad. It's just your body's way of telling you something needs to change. And we'll get into that a little bit more as we go through. And then we want to encourage self-management. So the last thing that I want as a chiropractor is for someone to be completely reliant on me for the state of their physical health and well-being. Okay, we want to, as much as possible, give people really helpful tools, ideas, strategies, exercises, stretches, philosophies that help them to manage this pain at home so that they can be as non-reliant on me as possible. There are plenty of people out there in the world with low back pain. I really don't need people coming in every week saying, I've got pain and now you have to fix it. We want to try to empower people to be able to manage their pain as much as possible. Research has made it very clear that this is much more conducive with a higher degree of quality of life in people who are low back pain sufferers. So as much as we can encourage self-management, this is absolutely our preferred approach. And really that's what this webinar is all about today. So we have processes that we work through. This is kind of a very high level summary on how we would work through someone who's got low back pain. So firstly, if they present to me in clinic, there'd be a thorough evaluation so that we could try to figure out, like we spoke about a few slides ago, what was actually causing the problem and how we can get to that mechanism. We look at people's goals, like we spoke about, then we come up with a management plan which has different aspects to it. We monitor that as we go along, and then if they're getting better, great, and if we can discharge them when they're all better and they've met their goals that we spoke about earlier, then terrific. But if we need to adjust course because the management plan is not working or something has changed or they've received an aggravation, what have you, then we do that, and we kind of keep going through this loop until we can exit the patient onto a happier course where they're able to self-manage. So in terms of implementing this management plan, we go through a little bit of this today. So there's a lot that we could talk through when it comes to implementing a management plan. There's passive strategies, there's active strategies, lifestyle and activity modification, talking about relative rest and how to get that while still sort of being able to work or play sport within the bounds of what is possible for someone who's experiencing some low back pain. There's lots of different physiological therapeutics which kind of form part of that active management. And then in some cases we consider supplementation as well. For example, if people sort of got some flare-ups of inflammation which might be driving part of their pain, sometimes we can use fish oils, glucosamine sulfates, magnesium supplementation and these sorts of things to help bring that down and give the body some of the raw material that it needs to control that. So there's a lot to talk about. This webinar, we don't have time to go through all of that. So what we're going to do today is we're going to go sort of, we're going to wade about hip deep into the pool of active management, okay? Even within active management, there are many different types of, so when we talk about active versus passive management, for people who might not be familiar with these terms, passive management is basically anything that I do to a patient. So these are things like spinal manipulation or dry needling or joint mobilizations or soft tissue therapies or things of that nature. And then active management are the things that the patient actively does themselves rather than passively sitting or laying there and receiving. So active management are things like stretches, exercises, really in some ways activity and lifestyle modification would come into that as well, but they are things that the patient is actually doing to drive their own health, well-being and recovery. So this is where we're going to be going today. This is what we're primarily going to be focusing on. So even within the active management plan, there are many different levels, different categories, if you like, of exercises or stretches or activities that someone can do, and they generally come under the realm of mobility, stability, coordination, strength and endurance. Today we're going to do a little bit of these. I've deliberately chosen some exercises to go through which kind of hit all of these, with perhaps the exception of strength. We may not get through much of that today, but there's definitely some mobility, stability, there's definitely some coordination, there's definitely some activities to help you focus on endurance. Strength is the tough one, requires a little bit more care, a little bit more sort of tailoring to the individual, so probably not the most appropriate one to go through on a webinar today, but we will get through some very helpful advice. All right, really quickly, what is meant by low back pain? I don't have a fancy slide for this. I'm going to do this very, very simply. Low back pain is pretty much anything from the lower margin of the ribs, so round about down through here, to the gluteal fold, okay, which is here. So pretty much anything that falls in this region here is referred to as low back pain. Don't need to make it any more complicated than that. We all know where our low back is. It can include the hip. Hip and low back share a lot of sort of common muscle and connective tissue regions. So there are things that are hip problems that cause low back pain, or there's low back problems that cause hip pain and vice versa. But generally speaking, low back pain is everything in this realm here. There's a few facts about low back pain that are really worth knowing before dealing with some of the things that are worth forgetting that you might have been told. One of these is that low back pain is now, and has been for a while, the biggest cause of disability in the world, and it's worse in developed countries, which is probably no great surprise because a lot of what is believed to be behind the cause of low back pain are certain what we might call lifestyle diseases, largely focused around the fact that we're quite sedentary, diets can be fairly pro-inflammatory in a lot of ways, and there's a bit of a perfect storm really in creating the kinds of problems that culminate over a long period of time in low back pain. Low back pain is often recurrent, so about 70% of people who experience low back pain will experience a recurrent episode within a 12-month period. So it's a very high relapse rate, and it's worth keeping that in mind when we speak about this. Even though most cases of low back pain will self-resolve really with minimal intervention over the first sort of 1 to 3 months of that occurring, there are very high rates of recurrence within the 12 months following that time. And unfortunately, about 5 to 10% of sufferers will develop chronic pain that will last for 3 or more months. Very complex, quite unfortunate. In terms of who it is that's developing these chronicities, there are some ways of being able to predict your likelihood of that. So it becomes more common to become chronic if you have symptoms which go below the knee, as well as the presence of particular psychological and depressive conditions. And then what we call psychosocial factors. So these are things like low expectations of recovery or fear of movement and re-injury. Pain which is more intense is more likely to become chronic. It's no great surprise. And this is why I'm so careful with the types of beliefs that we encourage, because people with a passive coping style, that is to say, we expect someone else to solve the problem for us rather than feeling empowered ourselves to come and take care of this problem, these people are more likely to develop chronic pain. And this is why I firmly believe that we should pay very, very close attention to the beliefs that we encourage in our low back pain patients as allied health professionals. In terms of who gets low back pain, so you have to forgive me, I am still an epidemiologist as well as a chiropractor, so these very epidemiological, who's at high risk public health types of facts I think are really worth knowing. So it's most common in working age adults. Okay, so it's not necessarily the young or the old. It's really largely people from 25 to 45, 50 years of age who are the most likely to get low back pain, believe it or not. It's more common in women, and especially if they're pregnant, than it is for men. It's also more common in people who are overweight, people who smoke, and people who have low levels of physical activity. So like we spoke about before, some of these very sort of lifestyle-driven types of factors. It's also more likely for people with certain kinds of health conditions, such as asthma, diabetes, people who are headache sufferers, and like I mentioned before, certain types of psychological conditions. And also in people with manual jobs, especially if those involve awkward postures or repetitive tasks and heavy lifting. This is a chart that I really like that sort of sums up who it is that is actually getting low back pain. So you'll notice that it really is most common in people sort of these age groups just here, but you'll also notice that low back pain pretty much doesn't discriminate, okay? Unless you're below the age of 10 years, in which case you're pretty safe from low back pain for the most part. But otherwise, people sort of from their 30s, all the way up through, like this is still like in women, this is still a prevalence of 30% in people in their 80s. So yeah, really, and not that much lower for men, still 20% of people in a 12-month period. So quite high levels. Doesn't discriminate by age. Discriminates a little bit by whether you're a male or female, but doesn't discriminate really that much. In terms of the causes, so this is worth knowing, because if you know what some of the causes are, then you can put yourself in a better position to be able to avoid some of the triggers for low back pain. With that said, one of the things really worth knowing is that most low back pain has no single identifiable cause. This creates a little bit of a problem for a lot of people who really want to be able to put their finger on something and say, there it is, that's what's causing the pain, this is why you're suffering currently. It's not always that simple. We're going to speak about shortly how to tell whether you need a scan, like an X-ray or an MRI or a CT. A lot of people want these because they're of the belief that it will help them to identify what's actually causing the pain. And unfortunately, it's simply not the case. And this is because low back pain is really very multifactorial. In most cases, there's no one single disastrous event that has led to that pain. There are some exceptions. People have had a fall, people have had sprain and strain injuries, people have had motor vehicle accidents obviously, and there are some people that have done something, maybe it's a lifting type of injury, but it can create some damage to some of the spinal discs, and then these can become quite sensitive, very, very inflamed, and that can irritate some of the surrounding soft tissues. But in most cases, there is actually no single identifiable cause. Slow build up over time is generally the story that we hear. So when people come in, the first thing we do is take a really thorough history where we ask them quite a lot of questions about when the pain occurred, what they were doing when it occurred, whether they're able to identify sort of any triggering event. In most cases, it was there and then it wasn't, and it was a slow build up over time, and it was kind of okay, but now it's not because it's stopping me from doing ABC activity. This is a very typical kind of story, rather than I was in a car accident or I lifted something and then I got injured. These sort of single kind of cataclysmic events are the exception rather than the norm. It is, however, I suppose, more common to see certain characteristics in terms of people's spinal movement control and how much stiffness they've got in their lower back. And there's some research that suggests people who don't move their back quite as well are more likely to develop low back pain than people who move their back very well. Should surprise nobody to hear that. All right, I really want to deal with this idea of should we get a scan, because there'll be a lot of people watching this webinar who are wondering, all right, maybe I need an X-ray, maybe I need an MRI, maybe I need a CT. I've got a friend who got one and that really helped them. One of the hardest things for me to convince people of is this fact, okay? Only about 10% of people with low back pain will need a scan. The reason for that is that we only take scans if we believe it's going to change the way that we manage the problem, okay? Which normally means we're trying to rule in or out a particular issue which if found to be positive or negative, would change the way we manage it. For example, if someone came in and they reported a particular lifting injury, they had a physical examination that suggested that there was some irritation of one of their discs, maybe we were a little bit concerned about whether that disc was irritating a nerve or part of their spinal cord, that would absolutely warrant a scan, because if it is impinging on a nerve or a spinal cord, then this has very high potential of changing the way that we would manage and go about treating that patient. So these are the people that get imaged. The people who don't get imaged are the people who don't have things like red flags. So red flags are things like unexplained weight loss, pain which is waking you up at night, or something which is kind of really unusual and strange about that pain that we're not able to explain. These are the people that we tend to prefer imaging with, especially if they've had trauma. Maybe we're trying to rule out a fracture or a dislocation. Certain types of neurological symptoms. So neurological symptoms are things like numbness or tingling, muscle weakness, burning or radiating or lancing kind of pain that we know is following a particular nerve pathway that makes us think, okay, maybe that nerve is under a little bit of a threat and we should do something about it. Or people that have had a lot of treatment but have had virtually no improvements. Okay, that's normally a sign for us that something is not as it seems, and these are the kinds of people that will be referred out for a scan. The reason that we try to be conservative with these scans is because they have hidden risks. Okay, so the first one is obviously the cost, okay, but also this risk of overdiagnosis. So it is really, really common for us to take a scan of someone and find something on that scan that has absolutely nothing to do with what's causing their problem, but it can mean that they then get diagnosed with something that then requires some more tests. Sometimes those tests have certain risks that come with them, and they can then end up being referred for interventions like surgery or treatment that they actually don't need, and because the issue that was found, and it might be something like for example, we find people that have got what are known as congenital anomalies, in terms of they might have an extra bone in their neck or in their lower back. Nothing to be concerned about, normal variations, but given the wrong information, these people can still be sort of made to stress and panic over this and go to their doctor for help. And the doctor, wanting to be cautious and not get sued, will go and refer for more testing, and before long they're having interventions that they didn't need to have, that then cost money and come with their own risks. There's also obviously radiation exposure, so we don't like to give people radiation from x-rays or CT scans if we don't have to. And this is a big one, and this is it's hard for me to convince people that this is a bigger problem as it is. So I'm going to use a story. I treated a patient once, her name was Mary, and she came in with, she had some neck pain. She'd gone to her doctor who'd ordered an x-ray, and her doctor said, "You look like you've got the spine of a 70-year-old. And Mary was about 40 at the time. And this freaked Mary out quite a lot, because she thought it meant her spine was really damaged and broken beyond repair, and why is my spine already 70? I'm currently only 40. That means by the time I am 70, my spine's going to be 100 years old. And just really unhelpful, caused her quite a lot of panic. And most of my treatment with Mary that day was actually just reassuring her that she did not have the spine of a 70-year-old, that in fact all she had was a bit of straightening of the normal curve that was in there, which, while it might predispose her somewhat to pain, does not change the management, and also doesn't mean that she's going to have any long-term problems from that pain. And when we sort of spoke about it, she said, "Yeah, you're right, actually, the pain's been getting better." I said, "Well, that's really good, because the things that you're seeing on that x-ray, they're not changing. So the fact that your pain is getting better, and in fact those features that you're seeing on the x-ray, a little bit of arthritis and some straightening of that neck curve, they've probably been there for 15, 20 years or more, and the pain that Mary had only been there for about 3 weeks." So no strong correlation, in fact no correlation at all between the presence of those findings on the x-ray and the pain that she'd been experiencing. But the fact that the x-ray had been taken, something had been found on there, and then she was given very unhelpful beliefs about that, created quite a lot of panic and stress, and a really significant decrease in the quality of life, despite it not having anything to do with the pain that Mary was experiencing. So this is why we try to be very, very conservative and diligent on the reasons we take x-rays. I hope I've convinced you of that. I may not have, and if so, that's okay. I do lose some of these battles, but hopefully there'll be some people sitting at home watching this who are going, okay, maybe I don't need a scan. And it's probably the case. It's 90% likely to be the case, unless these things. Okay, good. Let's move on. All right. Some other unhelpful things you might have been told, and I won't spend too long on these, but they are worth addressing because, Tommy down at the pub might have said something, or, Sally at daycare, one of the daycare mums might have said something that can throw a spanner in the works. Okay, so firstly, anyone who's been told that you've got a bone out of place, you have not been given good information, and that's me putting it that way. I'm going to try to demonstrate to you just how difficult it is. Okay, so here is a model of the human spine, okay, with all of its glorious vertebrae in there. I'm going to zoom in on the low back here. Okay, here is all of the ligaments and fascial tissues that are helping to hold this in place. Okay, so there's ligaments around, or joint capsules rather, around all of these facet joints. There's ligaments that run in between some of the bony prominences of the spine, and then on both the inside and outside, there's these really big, thick ligaments that run up the entire length of the spine. They run this entire duration. And that's before we get to how well locked down this is with muscular tissue. So there's one layer of muscle, okay, and then there's another, and another, and another, and another, and another. Long story short, these bones aren't going anywhere, and if they do, you would be in so much pain that you would not be watching this webinar, I promise you. So anyone who might have been given this information, I assure you, you are very safe ignoring that information. All right. Oops, excuse me, I'm on the wrong program here. That's what I'm looking for. All right, so your bone is not out of place. I spoke about this before, so I won't spend too long on it now. There is not one single identifiable cause of your problem unless you're a motor vehicle accident, lifting injury, sprain, strain, falls, some of the things falling under that category. As I spoke about before, Mary, if you're at home watching this, you do not have the spine of a 70-year-old. Your spine is just as old as you are. Some of them have a little bit of wear and tear, same as like if you were to look at the knees of most people, they've got scars on them from being a kid running around and scraping your knee, and you get a little bit of scar tissue. These are just the signs of having lived. They are on both your skin and they are also on all the joints throughout your body. It's okay, it's normal, it's natural, it's not going to cause most of you any problems whatsoever. This one I want to approach with caution, I guess, because there are certainly some times where you shouldn't do certain activities. But all too often I hear people that are told you don't have to run anymore, you shouldn't run anymore, you shouldn't go to the gym, you shouldn't train your combat sports anymore. Most of the time this is not true. The times that it is true are in the very extreme circumstances, and it should normally be quite temporary. There aren't many low back injuries I've seen where it's meant that someone couldn't go back to the gym, couldn't deadlift, couldn't clean and jerk, couldn't go do jiu-jitsu, couldn't go do boxing, couldn't work in the garden, all these sorts of things. Spines are robust. They're made to move. They're made to take strains on a fairly regular basis, and they're also made to heal really quite well. So if you've been told you can't do certain activities anymore, drop me a message. I'd love to chat about it with you, because in all likelihood you can. Maybe you need to be a little bit careful, but most of the time we can do the activities that we enjoy, so long as we're not doing anything that's likely to damage the spine. And normal activities, workouts, sports, home maintenance do not damage the spine. Also, this idea of posture being the problem, so this is another common one. There's a lot that could be said about this topic. Suffice to say, we've all had an experience where we sit at home in a particular position, and maybe we're not sitting with the best posture, whether we're watching TV or we're doing something on a computer, and we've started to feel a little bit sore. And then as we started to feel sore, we've changed position. This is because that soreness is one of the very fancy, complicated mechanisms that the brain has for making sure we're not causing ourselves any pain and long-term damage. So generally speaking, it's not posture. You won't stay in a posture long enough to do that damage because the soreness and discomfort will kick in long before you really do any problem. You might feel a little bit sore and niggly sometimes, but this is not going to do any dramatic injuries from which you will never make a recovery. So, good collection of things that if these have been in your mind, you can fairly safely just pick them up, move them to the side, and never revisit them again. All right. Let's start getting into the reason we're all here. So the goals of treatment. So obviously when we're talking about treatment, there's different types of treatment that match with different goals. Generally speaking, this is sort of the big one, right? No one wants to be in pain. Most of the reasons people come to see us is because they want to remove the pain that they're in. This often is also accompanied by I can't move as well as I would like to, and so I'd like to improve my mobility. We'd also like to reduce the risk that things are going to get worse over time, get back control, and try to return to normal life as possible. There's professional treatments. I'm not going to spend too long on these. There are lots of different modalities that we use to help manage different types of spinal disorders and low back conditions. I'm going to flip through some slides really quickly here. If you want to slow them down and have a read, feel free, but it's not really the main point of this webinar. Here's some information about spinal manipulation for people who'd like it. Same with soft tissue treatment. Feel free to pause and read these if you would really like to. Dry needling is a thing that helps some people. We do a lot of exercise prescription in this clinic. We also do, excuse me, I might be missing a slide. And I don't really know how to go backwards. That works. Yeah, might be missing a slide on avoidance of modification activities, but we have spoken about that. So let's get into why we all came here today. So self-management. So earlier we spoke about there being, just the slide up here, mobility, stability, coordination, strength, endurance. Okay, generally speaking, these are the types of categories for active management. We're going to go through some of these today. So yeah, promise I'll get the hang of this. All right, we're going to go through some of these today. We're going to do a few on mobility. So this top three here, okay, these are all mobility related activities. We've got a few that are going to be on stability as well. So these are going to be largely the side plank and the glute bridge are going to be stability focused. I'm sure no one can read this, but it makes me feel good to write it. There's also going to be, so really to a degree, the bird dog, and in some ways the glute bridge. These are coordination types of activities. And then the wall sit is really going to be the one that we look at for endurance. But there will be some variations of the bird dog and the glute bridge, what a mess I'm making, that are also largely endurance related. Some of these might come under strength, but not really, so I'm not going to delve too deep on that. Okay, so this is the part where you start looking at the whole point that we're here today, which is learning how to do these exercises well in a manner which is going to help to improve your low back pain. So the cat camel is a tremendous spinal mobility exercise. Okay, what I'm going to do is I'm going to put a little link on this webpage, which is going to have all of these in a handout with the how-tos, which is why I haven't crammed all the how-to on here. This is so I can explain them, and then you can have the handout, which is going to help you actually sit there at home with your free handout and go, right, here are my exercises, here's the mobility I'm doing today, here's some of the stability exercises I'm doing today, here's some of the coordination or endurance exercises that I'm going to do today. So cat camel, when we're doing this, things to focus on, you're going to feel when you do this like you want to bend your elbows. Okay, try to keep your elbows straight all the way through this. That is kind of a big one. The focus is on nice, slow, fluid movement. Okay, so each repetition should take about 10 seconds. I promise that does actually say seconds. Nice and slow, 5 reps every time you got to do it. You can't overdo this. So if you want to do more, then go for your life. But focusing on as you come in through so let's call this part 1, call this part 2. As you get to part 2, squeezing your glutes together so that you're kind of pushing your hip forward, okay? As you focus on trying to spread your shoulder blades apart and push them up towards the ceiling. During part 1, make sure to sort of arch your neck, pushing your belly down towards the ground and sticking your glutes, your butt up into the air, okay? All that will be on that handout. Hip flexor stretch. The reason I love the hip flexor stretch so much is because so many of us spend so much of our day sitting. When you're sitting, your hip flexors and your hamstrings are both in shortened positions, so the muscle stretch receptors in there start to get used to that as being their natural position, which means when you stand up and they lengthen somewhat, that feels as though they are stretched, and this can contribute towards, there's different names for it, an anterior pelvic tilt or a lower cross syndrome. Doesn't really matter too much what it's called. The fact is, stretching out your hip flexors is a really, really tremendous way of improving the mobility of your lower back and stopping a lot of that tightness that occurs from sitting during the day. Big thing to focus on when you're doing this is, so let's say this lady here, it's not entirely clear from this very two-dimensional image, let's say she's got her left knee on the ground, let's call that left. Okay, while she's doing that, we need her to be pushing that left hip forward, and the best way to do that is by activating, so squeezing your left gluteal muscle. Think of trying to use your glute to squeeze that hip forward, okay? So using that glute activation from the back, push that hip forward. It might help some people, as long as you don't have too much low back pain, which is aggravated by this movement. It might help some people if while you're doing this, you go to lean back, okay? And gently lean away from the hip that you're stretching. That can increase the amount of stretch that you get through your iliozoas muscle, which is two muscles together, your iliacus and your psoas, but they're kind of very joined when we look at them anatomically, so they get referred to as your iliozoas. Great exercise. Hold this stretch for 20 seconds, then do the other side and repeat 3 times. Tremendous exercise, highly recommend. And then stretching the other one, stretching the glute. This can be difficult to do. You can do it laying on your back, you can do it sitting. There's no reason to do it one way or the other than you find one more convenient, okay? But very simply, you just kind of put one foot up on the other knee, and then I just want you to focus. I don't know if this camera's going to catch it. Maybe if I move here, hopefully you'll still be able to hear me. Okay, so one knee, one foot up on your knee, okay? And then focus on bringing that knee up towards the opposite shoulder, and you feel that stretch through the glutes of the knee, which is up, okay? So at the moment, I'm here, I'm pulling my shoulder towards that knee. I'm gonna feel that stretch through my right glute, okay? Hold it for 20 seconds, then do the other side. Repeat 3 times on each side. Do it as many times as you need to during the day. You absolutely cannot stretch your glutes too much. You can be really silly. You can prove me wrong if you wanted to. It's very difficult to do. If you happen to do it, shoot me an email. I'll give you a prize, because it's very difficult to overstretch your glutes. So go for your heart's content on this exercise, okay? All right. After that, the next one we're going to go through is the side plank. Now this is a tremendous exercise because this pays a lot of attention to these often neglected lateral trunk stabilizers. And when it comes to preventing and managing low back pain, good trunk stabilization, good trunk stability really cannot be overstated in terms of its importance. And a lot of the core exercises that are out there these days, they don't probably pay enough attention to some of these lateral stabilizers in terms of like especially the internal external obliques. So this is an exercise very well recommended by a lot of very well regarded low back pain rehabilitation researchers. A couple different ways to do it. Again, let's call this position 1, position 2. Position 1 is probably a good start. You can also have your knees bent. If you're, that's my photo. That's my drawing of someone having their knees bent. If you're that way inclined, it can just provide you a little bit more stability. Things to watch out for is when doing this exercise, no matter which position you're in, you really want to make sure that your shoulders, your hips, your knees, and your ankles are all in the same plane, which is to say not rotating, okay? So don't be in that side plank position, but have your shoulders rotating inwards or outwards, or have your hips rotating down somewhat separate from your shoulders and knees, okay? You want that nice neutral spinal position that whole way through. Even if you're progressing to position number 2 and making it a little bit more challenging. I'll also note, this was one of the better images that I could find for this presentation. There's no great need to have your hand over your head. Place it on your hip, place it across your chest. Just don't place it, like dangle it in front of you, because that might encourage you to start to rotate your shoulders in that direction. Probably resting on the side or on the hip is probably the best position for this exercise. When you're doing it, I recommend for this one, holding 30 seconds, okay, on one side, then have 30 seconds rest, and then do 30 seconds on the other side. And this is a really good sort of trunk stability exercises that also builds into a really good endurance exercise. One of the better ways of doing that is sort of through a method known as the reverse pyramid, okay, so in pyramid exercises you might start with 1 rep and then 2 reps and 3. This one you're starting with the higher time first and then going for lesser time as you fatigue, so that you can prioritize movement quality, okay? So 20 seconds one side, then on the other, and then rest, okay? And then 20 seconds on one side, then the other, and then rest, and then 10 seconds one side, and then the other, and then rest. And then have, like a good couple of hours before you go and hit that again. Again, hit it as many times as you want during the day. Aim for 3 or more. 5 probably better, but 3, look at that as the minimum serving for a daily regime of this exercise. Again, more notes will be in the handout just down the bottom, so you should be able to find that link down here somewhere. Glute bridges. Okay, advice with glute bridges. Even though in the images here, the person got the hand by the side, I encourage patients to actually have their hands actually on their glutes when they go to do this, so that you can feel them activate, okay? So in this first position, okay, start by squeezing your glutes together. You should be able to feel them activate underneath your fingers as you squeeze them, okay? And then start using your glutes to drive your hips up into the ceiling, holding that position, and you want to try to relax your hamstring muscles as much as possible. You might find a tendency to kind of press your heels into the ground, and that'll start to activate your hamstrings. If you find that you're doing that and it's difficult to stop, what I recommend doing is doing this exercise actually up against a wall, so that your toes are against the wall, and then you can gently feel like you're sort of pushing your toes into the wall, which will activate your quadriceps muscles, so your quadriceps muscles being your knee extensors, which will stop your knee flexors, i.e. your hamstrings, from activating. And when you start getting used to that with the glute bridge without your hamstring activating, then you'll be able to do it you should be able to start doing it without having to push your quads into the wall, push your toes into the wall by activating your quads as you go to do it. Again, when you go to do this, start with 30-second holds, 30 seconds off, start building to a point where you can do 1-minute holds, keeping your fingers on your glute, so just on the outside of your butt cheeks, so that you can feel that those muscles are actually doing the work when you're up there. Again, it's a good stability exercise that builds into a really, really good endurance exercise. Okay, then we get to one which got a very weird name called the bird dog. I'm sure there's a great reason why it's called that. I've never looked into it, so don't ask me. Key things with this one is you'll find, and the reason I love this image so much is because the image has got a really tremendous, nice, neutral spinal posture the whole way through. Both these positions are maintained very well. There are variations on this, okay, but points to remember is that elbows staying straight. Let me choose a different color. Elbows staying straight the whole time. Wrists are directly underneath the shoulders, okay, and knees are directly underneath the hips when doing this exercise, keeping that nice, stable, neutral spine position the whole way through, so not allowing the shoulders or the hips to rotate as you go to bring up one arm and the opposite knee. Try to bring them up in unison, okay? If you can't, it's okay to just do one at a time until you start getting used to being, on only 2 points of contact rather than having 3 points of contact if you bring up one arm or one leg. when you go to bring up the leg, a lot of the tendency will be that your torso will start to sag through the middle here. Keep it nice and rigid, keep it nice and strong, maintain that good neutral spinal position, and then hold that position for 10 seconds. So slow 10 seconds up into that movement, emphasizing the control of that movement. Slow 10 seconds, hold for 10 seconds and then slow 10 seconds down, emphasizing control, trying to smooth out that movement. You're gonna feel when you do this, especially the first few times, that there's a bit of sort of shakiness and lack of coordination and balance. The more you practice, the better and the smoother that will get, and that smoother movement will translate into much better spinal and core control. Great. Okay, and then one of my favorite endurance exercises. Now, even though this is more of a glute and quad exercise than it is a low back exercise, the reason I love it for low back rehab is two reasons. Firstly, glutes and quads, really useful muscles of independence, help us get up from sitting positions properly, help us squat properly, very good fundamental sort of spinal control movements. But also, this exercise, even though it's called a wall sit, this is the opposite of sitting down, okay? The reason it's the opposite of sitting down is because when you're sitting down, your glutes and your quads are doing nothing, okay? In this position, your glutes and your quads are going to be doing a whole lot, okay? If you've not done this exercise before, proceed with caution, okay? Hips and knees at 90 degrees when you're going into this position. Focus on having your toes pointed forward, but your knees sort of gently driving out, because that'll help you to engage your glutes. Hands on the hips is a really good idea. However, if you're worried that you're not finding whether your glutes are activating, then putting your hands actually on your glutes instead of on the hips, and just kind of feeling that glute activation, or squeezing. Imagine that you're trying to hold a piece of paper in between your butt cheeks. Please forgive the potential graphicness of that metaphor. But squeezing glutes together, you should be able to feel that muscle move underneath your fingers when you go to perform that movement. Driving your knees out ever so gently so that you keep engaging those glutes, and you will feel very quickly, especially if you're not used to this exercise, that your quads are going to burn quite a lot when you do this, okay? It's a good thing. Start slow, okay? Start with 10 to 20 seconds if you're a beginner. If you're a little bit better, then aim for 30 to 60. And you really want to get to a point where you can build up and do this for 120 seconds pretty comfortably. But I recommend going in small increments and increasing over time. Again, you can't overdo really any of these exercises, so do it to your heart's content, but 120 seconds in that position without swearing and cussing is the goal. Okay. All right, those are all the exercises I wanted to run through today. Some key messages just to hammer home some points here. Back pain is common, okay? You might feel that you're the only person who's really suffering to this degree. You're not alone. There's a lot of people out there. If you talk to some of your family and friends, you'll find a lot of them have experienced these kinds of aches and pains. A lot of your colleagues at work will have experienced them as well. It is common. It doesn't mean you're old. It doesn't mean you're weak. Low back pain does not discriminate, okay? It's a very, very common condition. Men and women of working age, really, as we saw in one of the earlier slides, all the way up until into your 80s. In most cases, there is no single identifiable cause, and in most cases, a scan is not required. Hopefully I've convinced you of that. I often fail, but I try really hard. The most important question surrounds what is actually driving the problem and how to get to that mechanism. So the exercises that we've gone through today, they're tremendous exercises. They are, in a lot of ways, a one-size-fits-all kind of approach. I've tried to keep them fairly high level, fairly broad, fairly applicable, and sort of adaptable depending on your own circumstances, your own physical condition. Back pain treatment, though, is really all about trying to identify what are some of the driving factors and figuring out how we can get to them. So do keep that in mind. Really hard to go past the value of like a thorough assessment to try to pinpoint some of those factors and design a program like this, which is really tailored specifically to the factors that are driving your particular problem. If you need help with that, do feel free to shoot me an email, especially if you're in the Moonee Valley. I know a lot of people, Greater Melbourne kind of area as well. Please feel free to shoot me an email. I can put you in touch with someone really without too much trouble. And that brings us to the end of this particular presentation. So I hope you got something out of it. Feel free to pass it along to your family and friends if you think they'll find it valuable. Digest it for a little bit, maybe watch it again in a few days or a few weeks, because you'll take more out of it the second time. And do make use of those handouts that I'll include a link somewhere on here. I might even be able to work out how to include this video. I do occasionally surprise myself with my use of technology. Thank you for your attention. This has been a 40 or so minute presentation, and I know some of the information sometimes can be difficult to take in. I hope I didn't go through it too quickly, but I was trying to take advantage of the time that we've got to go through this and provide some useful information, some useful context and background, so that you have a good understanding of why certain exercises are better or worse than others. All right, any questions, anything I can do to help, please anytime shoot me an email. If you're wondering where I work in Travancore on 252 Mount Alexander Road. Would love to help out anyone who's struggling with these and needs something more than just a generic approach. Otherwise, please find it useful. Please put it into practice. The best exercises are the ones that you do. No exercise helps if they don't get performed. No stretch helps if it doesn't get performed. Start with these. They are a very, very good set. I give them to a lot of my patients. So with that, I'll sign off. Best of luck. Thank you very much for your attention. Until we speak again, I'm Hayden McKenzie, and I'm out.